So let's have a case. This is hypertensive diabetes, renal transplant a few years ago on immunosuppressive therapy. Now the creat is 2, presented with exercise intolerance and dyspnea, and this patient has severe aortic stenosis, good LV function. Angiogram is normal. So what do we do? Surgery or TAVR? So heart team plus renal transplant team decides that TAVR would be a better option. Why? We have limited data for TAVR in post-renal transplant patient. However, with the available data, with TAVR, we have shorter hospital stay, less chance of acute kidney injury, less chance of infection, and less chance of stroke. And how do we work up the case? Yes, cardiac MR with non-contrast CT would be a good combination along with TE or 3D TE. But then we are so much used to having the CT analysis that right away if we are asked to do assessment of valve based on cardiac MR, non-contrast CT and TE, it's not always easy. So we have an alternate option to discuss with the radiologist and have a CT analysis with less amount of contrast with nephroprotection. And some special considerations, of course, the nephrologist will not allow us to use the right femoral access. So our access would be only left femoral, and we need to study that carefully for calcification, which is quite common in CKD and post-transplant status. Otherwise, crossing the valve and advancing the valve is standard, nothing different. The excess calcium of the valve will allow us to position it quite easily. Otherwise, if the valve calcium is less, you can put a few pigtails or wires, Teflon wires to position them. And for positioning, we can use a transesophageal echo as well. And in case there is, for double confirmation, we can have a minimum amount of contrast just at the time of deployment, just to be doubly sure that everything is perfect. And post-deployment, we can have transesophageal echo for assessment of paravalvular leak. Like in this case, you can clearly see that there is a significant amount of paravalvular leak, and the hemodynamics also will help. And in such a case, we can have slight excess contrast in the balloon and redilate again, as in this case where the paravalvular leak has disappeared. As usual, this patient did well with a pre-discharge echo gradient showing less than 10, and immunosuppression will be managed by the renal transplant team. They do not stop it. The oral steroids will be converted to IV steroids, and blood transfusion as usual is usually not required. However, if required, then we should keep standby the leukodepleted RBCs so that the transplant kidney is not into problem. So close teamwork with cardiologist, cardiac surgeon and renal transplant team is quite important. Take-home message will be less AKI, less infection, less stroke, less hospital stay. So TAVR is preferred. Combination of MRI, non-contrast CT and TE helped to reduce the contrast usage, and right femoral access should not be used. Thank you very much.